Hi there, my valued and highly treasured viewers and listeners, and welcome back. My name is Dr. Nath Arwa, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I urge you to sit back and spare me part of your precious time to share with you a few tips. So welcome. Welcome to part 18 of our series. In question 1, you have a 42-year-old male patient in the ICU who is mechanically ventilated due to acute lung injury. He is sedated using an agent which is known to be a centrally acting alpha agonist with minimal effects on his respiratory drive. Which of the following sedatives listed below is he likely to be receiving? Is he receiving Lorazepam, Dexmedetomidine, Propofol, or Midazolam? I'll give you 10 seconds to choose the correct answer. So the correct answer is B, Dexmedetomidine, which is otherwise known as Precedex. It's a highly selective centrally acting alpha-2 agonist which is commonly used to sedate mechanically ventilated patients in ICU across the globe while still needing to maintain their respiratory drive. It can be handy in weaning patients from the ventilator since such patients need the strength of their respiratory systems to aid in the weaning process. Now, both Lorazepam and Midazolam are benzodiazepines which augment the activity of GABA, thereby causing hyperpolarization of neurons. They can affect the respiratory drive at high doses. And then C, Propofol, is classified as a general anesthetic which also potentiates the activity of GABA. So with that explanation, B becomes our best choice. Let's move to the next slide. Which of the following non-depolarizing neuromuscular blockers has the longest half-life and duration of action? Is it Pancuronium, Cisatracurium, Succinylcholine, or is it Rocuronium? I'll give you 10 seconds to choose the correct answer. The correct answer is Pancuronium, otherwise known as Pavolone. It has the longest half-life, 110 minutes to be precise, and a duration of action of up to 100 minutes. In comparison to the other agents that are listed there. Now, Succinylcholine is a depolarizing neuromuscular blocker with a unique pharmacokinetic profile compared to other paralytics in that it has a short onset of action and the shortest duration of action, around 4 minutes, making it ideal specifically for the short procedures but not for long surgeries. Sedative hypnotics need to be administered prior to giving patients neuromuscular blockers such as Succinylcholine, since without doing so, such patients can hear everything you are discussing, you are doing, and they can see and experience everything firsthand that is going on round about them while not being able to breathe on their own, and that can be a terrifying experience for a patient undergoing surgery. So I would settle for A. Let's move to the next slide. which reads, which of the listed sedatives stroke hypnotics has bronchodilatory and potentially inotropic effect? Is it Lorazepam, Etomidate, Ketamine, or Propofol? I'll give you 10 seconds to choose the correct answer. Answer is ketamine. Ketamine, otherwise known as Kettler, is a non-competitive NMDA receptor agonist which causes a dissociative anesthesia while simultaneously providing analgesia, pain relief. It has a potential advantage in asthmatic patients or other patients with reactive airway disease due to its bronchodilatory effect. It also has a positive inotropic effect which can be advantageous in patients requiring BP support or maintenance of hemodynamic support. Etomidate, otherwise known as Amidate, is a non-barbiturate sedative hypnotic agent which appears to be neutral on its effects on the heart at normal doses, so that would be the right answer. Then Lorazepam, otherwise known as Ativan, is a benzodiazepine which augments the activity of GABA, causing hyperpolarization of neurons. It is associated with amnesia, so that isn't the right answer either. Then Propofol, otherwise known as Diprivan, is a general anesthetic which also potentiates the activity of GABA, and it's associated with a reduction in inotropy, so that wouldn't be the right answer either. That leaves us with ketamine as the correct choice. Let's move to the next question. It reads, a patient with a past medical history significant for systolic heart failure with an ejection fraction of 20% is admitted to your ICU and is currently mechanically ventilated. He requires a sedative hypnotic agent. If Propofol were to be administered to serve that purpose, which of the following side effects would he be at risk of experiencing? Would he be at risk of experiencing a pulmonary edema or hypotension or acute tubular necrosis, or would it be adrenal insufficiency? I'll give you 10 seconds to choose the correct answer. So I would settle for hypotension. Patients with known heart failure, especially systolic heart failure that is associated with a poor cardiac output, are at a greater risk of hypotension when Propofol is used in their procedures. Hypovolemic patients are also at a greater risk for hypotension, which is why fluids, and I underline fluids, should always be available before or during the use of Propofol in any procedure, assuming such patients do not have fluid restriction. Now, pulmonary edema is a symptom of an exacerbation of systolic heart failure, but it isn't a common acute side effect with the use of Propofol. So that makes A the wrong answer. Now, Etomidate is a non-barbiturate sedative hypnotic which has been shown to impact cortisol production in the adrenal glands and put some patients at risk of adrenal insufficiency. So D would only occur with Etomidate, not with Propofol. Acute tubular necrosis doesn't occur with the use of Propofol at all, so that makes C wrong. Now, I would just like to remind you, dear listeners and viewers, that Propofol is a lipid-based emulsion for IV administration, and patients receiving it may need to have their triglycerides checked if you are infusing for long durations. So just take note of that. Let's move to the next question. Which of the following sedative hypnotics have the potential to cause adrenal insufficiency? Is it Etomidate? Is it Dexmedetomidine? Is it Midazolam or Ketamine? I'll give you 10 seconds to choose the correct answer. Correct answer is Etomidate A. Etomidate is a non-barbiturate sedative hypnotic agent which has been shown to impact cortisol production in the adrenal glands and thereby potentially increases the risk of adrenal insufficiency. Now B, Dexmedetomidine is a highly selective central acting alpha-2 agonist, which is also a sedative hypnotic, which doesn't normally suppress the respiratory drive, but it may lower blood pressure. It has nothing to do with the adrenal insufficiency. Then ketamine is a non-competitive NMDA receptor antagonist, which causes a dissociative anesthesia while also providing pain relief, analgesia. It has nothing to do with the adrenal insufficiency either. And Midazolam, which is C, is a benzodiazepine which augments the activity of GABA, causing hyperpolarization of the neurons and is associated with amnesia, not with adrenal insufficiency. So that leaves us with A as the correct answer. Let's move to the next question, which reads, a patient requires a paralytic agent for an emergent procedure. Which of the following would be a contraindication for the use of succinylcholine that should be considered if feasible? Is it hypernatremia? Is it hypocalcemia? Is it hyperkalemia? Or is it hyperglycemia? I'll give you 10 seconds to choose the correct answer. Answer here is hyperkalemia. Now, succinylcholine is a depolarizing neuromuscular blocker which is classically associated with causing initial muscle fasciculations followed by paralysis. Now, during the fasciculation phase, potassium can be released from the inside of the cell into the bloodstream, thereby increasing serum potassium levels. If the patient already has a high baseline elevation in potassium serum levels, this could increase the risk of cardiac arrhythmias due to hyperkalemia. The others don't really cause hyperkalemia as such, so this is unique to succinylcholine. So we need to be cautious about that. Let's move to the next question, which says a patient was undergoing rapid sequence intubation, abbreviated as RSI, in your ICU to protect his airway and received a neuromuscular blocker prior to the procedure. His body started demonstrating a rapid small muscular contractions which ceased within half a minute. So my question to you is, which neuromuscular blocker did this patient likely receive? Was it Cisatracurium? Was it Rocuronium? Was it succinylcholine or Rocuronium? I'll give you 10 seconds to choose the correct answer. So succinylcholine it is. He was most likely manifesting muscular fasciculations as a result of receiving the depolarizing neuromuscular blocker succinylcholine. This occurs because succinylcholine binds to the motor end plate and activates or stimulates the muscle to initially cause muscular contraction, which is followed by paralysis of the same muscle. The other listed options, which are non-depolarizing, do not cause muscular fasciculations. That leaves us with answer C, as the best option. Let's move to the next question. AJO is a 74-year-old female who lives alone, and she presents to your clinic for the management of a type 2 diabetes mellitus, which was diagnosed 3 years ago, and she manages it with 1 gram of metformin taken after breakfast and after dinner. Her past medical history is significant for hypertension, coronary artery disease, and she experiences recurrent urinary tract infections. Now her A1C today is 8.5%. She has an estimated glomerular filtration rate of 44, and she expresses concerns about hypoglycemia and would prefer a once daily regimen. Because of forgetfulness, she doesn't want those BD regimens. So which would be your next best course of action for this AJO lady? Would you discontinue metformin and start Empaglifozin? Would you discontinue metformin and initiate a basal bolus insulin? Would you decrease the metformin dose to 1 gram a day and start Alogliptin? Or would you decrease the metformin dose to 1 gram a day and start Glipizide, a sulfonyl urea? I'll give you 10 seconds to make the correct choice. I would settle for C. I would decrease the metformin dose to 1 gram a day and introduce Alogliptin. Now, for patients already on metformin with an eGFR between 30 and 45, it would be appropriate to continue with metformin therapy and consider a 50% reduction in the dose. Now, the addition of Alogliptin would be beneficial to her glycemic control, because we know that Alogliptin is taken once daily and has a low incidence of hypoglycemia. It isn't necessary to discontinue metformin at this stage, and similar to metformin, Empaglifozin produces cardiovascular benefits. However, I would be shy and reluctant to use Empaglifozin because this lady AJO has a history of recurrent urinary tract infections, which is a common adverse effect of Empaglifozin, making her a poor candidate for Empaglifozin. So option A wouldn't be ideal. Empaglifozin shouldn't be initiated when the eGFR is below 45. So that is another catch. Therefore, it would be unsuitable for this dear lady. Now, basing on her renal function, basal bolus insulin wouldn't be the appropriate choice for her, because this lady prefers a once daily regimen. Now, the basal bolus will involve more administrations of the insulin than once, so I would knock that one off. I would disagree with option B. And Glipizide, which is a sulfonyl urea, has very high risks of causing hypoglycemia, which worries our dear lady, compared to Alogliptin. Because Alogliptin is known to release insulin in a glucose-dependent manner. Now, metformin is the preferred initial pharmacologic agent for treatment of type 2 diabetes mellitus and should be continued as long as it is tolerated and not contraindicated. Now, our lady has not complained of intolerance, so I would rather continue with it, but at a reduced dose. It is, however, contraindicated in patients with an eGFR below 30. Now, initiating it in patients with an eGFR between 30 and 45 is not recommended. But because our lady was already on it, I would comfortably reduce the dose and continue using the same for her therapy. Now, just to add on, empagliflozin is a SGL2 inhibitor which increases urinary glucose excretion by blocking the normal glucose reabsorption in the proximal convoluted tubule. So that is how it causes a lot of peeing of sugar in the urine that promotes recurrent UTIs. It wouldn't be favorable for our patient in this case. Let's move to the next question, which reads, you are requested to make recommendations on what medication would be beneficial in the management of diabetes mellitus in a 66-year-old male patient with chronic kidney disease with an EGFR of 44. He is currently on metformin SA, takes a dose of 1000 milligrams orally once daily after his breakfast. Apart from that, he takes Saxagliptin at a dose of 2.5 milligrams, and he is tolerating the two of them well. There are no issues so far. His goal A1C is below 8%, but he is currently at 8.9. So what agents would you recommend for him which have proven beneficial in delaying the progression of CKD according to the ADA standards for diabetes care? I'll give you 10 seconds to choose the correct answer. Would you choose Pioglitazone? Would you settle for insulin glargine and insulin Aspart as a basal bolus combination? Or would you settle for metformin and the SU glipizide? Or would you settle for Canaglifozin, Empaglifozin and liraglutide? I'll give you 5 more seconds. Settle for D. Now, Canaglifozin, Empaglifozin and liraglutide have been shown to be beneficial in chronic kidney disease. Canaglifozin and Empaglifozin reduce intraglomerular pressure and prevent worsening of neuropathy. They also delay worsening of albuminuria, while liraglutide has also demonstrated a lowering incidence of neuropathy in clinical trials. Although it's appropriate to use both metformin and the sulfonylurea glipizide in chronic kidney disease, both of them lack sufficient evidence in delaying the progression of CKD. And the two insulins can be used in patients with severe kidney disease, but they haven't proven to be beneficial in delaying the progression of CKD. And Pioglitazone, I would be very shy to go there. It's generally not recommended in patients with renal impairment because of its potential to cause fluid retention. So that makes A, B and C incorrect choices. Let's move to the next question, which says, a 59-year-old African-American lady was recently started on levothyroxine at a dose of 50 micrograms orally once daily after her breakfast for a new onset hypothyroidism. When would you recommend she has a follow-up TSH test done to evaluate the effectiveness of this current dose of 50 mics once a day? Would it be after a week? Would it be after 2 weeks? Would it be after 6 weeks? Or after 12 weeks from today? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for 6 weeks. Now, after initiating the levothyroxine therapy, a repeat TSH should be drawn about 6 weeks after initiation. Now, levothyroxine has a half-life of about 7 days, and in order to reach a steady state, according to PK/PD, we require about 5 half-lives, and that will take 5 to 6 weeks. So that makes Answer C, correct. Let's move to the next question. A 57-year-old white male patient with a past medical history of CAD, hypertension, and dyslipidemia has been newly diagnosed with hypothyroidism at your endocrinology clinic today. His vitals include a BP of 123 systolic, 72 diastolic, a heart rate of 64, and he weighs 95 kilograms. He is currently managing his condition with 10 milligrams of amlodipine taken once daily, 40 milligrams of fosinopril taken orally once a day. He also takes isosorbide dinitrate at a dose of 20 milligrams every 8 hours orally. On top of that, he takes 100 milligrams of metoprolol twice daily and 10 milligrams of rosuvastatin at night for his dyslipidemia. The chemistry and lipid panels are within normal limits, but his TS is 78 million units per liter. My question to you is, based on the provided information, what would be the appropriate initiation levothyroxine dose for this gentleman? Would you set him off at 200 micrograms orally once a day after breakfast, or would you opt for 50 mics after breakfast, or 50 micrograms after breakfast, or 100 micrograms after breakfast? I'll give you 10 seconds to choose the correct dose. Personally, I would settle for 50, and here is the explanation. A full replacement levothyroxine dose is a typical in a typical patient, is usually about 1.6 micrograms per kilo per day. That's the optimal dose as quoted in literature. Now this, when you do a quick math, is approximately 150 micrograms for this particular patient, considering his weight. Now the recommended starting dose for him, in my opinion, would be 25 to 50 micrograms due to the history of a cardiovascular disease. Now this lower starting dose is recommended in literature to minimize the risk of worsening his cardiovascular disease symptoms, which include angina, because it would also, a high dose would risk cases of atrial fibrillation. That's why I would go slow and start low. Now this dose can then be escalated stepwise as tolerated until we attain the therapeutic dose that emerges from the quick computation that we did. So I would settle for option B. The rest would be too high and would end up with risks of cardiovascular events. Treasured viewers and listeners, that brings us to the end of part 18 of our Pharmacotherapy MCQs series. It was a pleasure imparting knowledge. I highly appreciate the fact that you continue to partner with me in this journey, and if this video helped you in any way, I would like to remind you to give it a thumbs up, to like it, and I would also like to urge you to subscribe to my YouTube channel if you haven't yet done so. I would like to promise you that the best is yet to come, and I want to thank you for viewing and for listening. I hope and look forward to interacting with you in part 19 of this series. Thank you very much.